So I'd just like to introduce you. Just delighted that you're here, Esther. And so Esther is an associate professor at UVic and has led the work essentially on encounter codes with the ministry, and her research that she has been doing with looking at that encounter code data and informing the NP services and what that should look like and how best to use that data. So I'll turn it over to Esther for a description of how the morning went and some of the question periods. I don't know if everybody heard, but just to write questions, they were going to use this is almost like a prototype of what Esther will be doing for the ministry. So that on the website we've got the links right now. There would be this opportunity to have a live visual to stream that, and so questions that are helpful would be helpful for Esther to take forward to add that onwards. So I'll turn over to Esther and we'll go over it.
And this is also being recorded and will be posted on Fraser Health's website at some point. So there may be some things that we don't capture here that we captured this morning. So I think between the two, then hopefully most things will be captured. The other thing about the questions is, doesn't mean that I won't answer your questions, and we can certainly ask your questions as we go along, and I'll try to respond. There are, what I've discovered is that there are things that are at the ministry level, that some questions that relate to the ministry, and some questions relate to internal systems level Fraser Health. And so there may not be may not necessarily be a good answer to the question, but at least I can say that's something that you need to take up with your manager, or that's something that Fraser Health is working on, whatever. It's not at the ministry level. And if it's at the ministry level, then how we're looking at addressing that. So in writing questions on here, the reason that I'd like to, if there are questions that you have, even if we answer them, I'm taking them back with me, and it's a way so I don't have to write down what your questions are, and it's a way of capturing where there may be some holes that we need to look at in what we're doing, because the PowerPoint that I have here is the PowerPoint that I've been using for the Ministry of Health tutorial for NPs. And so it's been helpful to think, okay, have I captured everything that needs to be captured? And what I heard back from one person this morning was that the discussion for people who are used to the codes and have been practicing as an NP, that this discussion was helpful, but for some people who were just graduating and just getting started, that they probably needed a little more detail. So that was good information to know, because I think that probably when this is up on the ministry website, there'll be a lot of new NPs that are looking at it. So this is a way for me to have a nice run through of, is this capturing what we need to capture for the website, for tutorials on the website. So having those questions to take back with me would be good. Hello. So I just want to let you know that just a little bit of historic background. I mean, some of you have been around for a number of years, and you've probably been coding for a number of years, or attempted to code off and on for a number of years, depending on what supports you had in place, or started and stopped, and we've seen all of that in looking at the data. But encounter codes were originally created when the nurse practitioner role was being implemented in BC. So in 2005, or before 2005, when they were looking at implementing nurse practitioners, what happened in the ministry is they basically said, okay, we need to have some kind of codes to track NP practice. So we'll basically take the physician fee codes and dump them into this manual and call them nurse practitioner encounter codes. And that's where they came from. And so that was released in 2005. There was a manual, a nurse practitioner manual, how-to resource manual. Again, there was a lot of data in there that really didn't apply to NPs, but again, it was somebody at the ministry kind of going through and saying, you know, okay, physicians need to know this, so maybe NPs need to know this, and so putting a lot of data together that really wasn't necessary. So you probably know that in probably 2012 maybe, that manual disappeared. So for people who are looking where'd the codes go and where'd the manual go, that came from the work that the Encounter Code Working Group was doing to say that manual hasn't been updated since 2005. There's a lot of information in that manual that really isn't relevant. So how about if we take it down and revise it? So that's what happened. That's how the manual got taken off. And now what's going to be up on this website, you've seen kind of that first draft of what it's going to look like. I hear from the ministry that their website is being totally redesigned. And so the look of the website will change, but the type of information that's on there will stay the same. So in 2000, the Encounter Codes initially were released in 2005. They were updated by a group of NPs in 2008. And there were probably some minor revisions that may have been made in 2010. And what we learned in talking with NPs is that in 2008, that NPs were saying they don't capture our practice. And we have to use way too many codes, and there's lots of things that are in there that we don't use, but they don't capture our practice. And we kept hearing that they don't capture our practice, they don't capture our practice. And so NPs were also saying, what are you doing with them? And nobody could tell anybody what they were doing with them, and they didn't have a way to capture it other than by hand. And so a lot of NPs just weren't submitting anything, which meant that there were a lot of activities going on by NPs that wasn't being captured in any way. So I was funded for a 3-year project looking at the integration of nurse practitioners that began in 2011. And for those of you who've been attending the BCNPA conferences, you've heard some updates of that over the years. But part of that original data, the original plan, was to look at NP encounter codes, because we wanted to know, what do encounter codes tell us? What can we learn about nurse practitioner practice from encounter codes? And so we started a journey that took a year to find out where they were located. And then once we found out where they were located, then we had to go through ethics approval to gain access to them. But as a result of just talking with the ministry about encounter codes and keeping them up to date on what we were doing with the research, the Sharon Stewart, who was working at the ministry and had some involvement in the NP portfolio and was in HR, contacted me and said, we'd like to update the encounter codes, and we'd like you to co-lead that effort. And so that began in 2012 to reconstitute by looking at NPs who had worked on the codes in the beginning, so to reconstitute the Encounter Code Working Group and bring together a group of people, so a representative group of people, so nurse practitioners from each of the health authorities who were representing their health authorities. And the charge was, whoever you're representing, then you need to go back, get feedback, and then bring it back to the working group. So we worked together to revise the codes for about a year. And then that final draft is the one that's on the ministry's website now, is the result of that work that we did, of the most recent revisions. So the terms of reference of the working group was to revise the encounter codes, to revise the resource manual, and to recommend strategies to educate NPs. So that's all part of this ongoing. Once we submitted the final version of the codes to the ministry, then we're kind of still in this rollout phase. So the most recent version of the codes, which you can download this from the website, that went live in October. There's actually going to be a revision to this, and I'll speak to this, but some minor tweaks that we've done to this that will be released in March. And so that's kind of that trajectory of where we've been going with the codes. The ministry saying, we're funding nurse practitioners. We want to have that data coming from nurse practitioners, but also recognizing that there's some things that data will tell you about NP practice, and there are other things that it won't tell you, and I'm going to go into that today. So that's just a little bit of a history of where we started, or how this has been ongoing since 2011, and I can tell you in 2011, I really didn't have a clue with how all of, where this was going to go and how to begin to make sense of this. And so I feel like only because I've been working with the ministry and working with revising the codes, there are things that made no sense to me that now I understand. So hopefully if there are things that you have that you're not, that you don't understand, we can have some of that discussion today. So I want to start out with just defining some basic terms that seem to be a little problematic for people. So Medical Service Plan, MSP, the reason that you see it this way with MSP/HIBC is because I'm told at the ministry that those two, it'll change and just become HIBC. So that it won't be MSP, it'll be HIBC. But right now they're kind of in that transition mode, so we're using both. But the purpose of MSP is to govern the eligibility and enrollment of beneficiaries. So this morning there was some discussion, if you're providing care to people who aren't beneficiaries, where does that money come from? And I can say that it doesn't come from MSP. And so if you are providing care for people who aren't enrolled in BC's MSP, then, and they're not eligible, and so some of that might be new immigrants to Canada. And there's been lots of discussion around, do we pay for new immigrants, and the whole issue of cutting back on refugee services that the federal government has done, and kind of that pushback that was coming from healthcare providers. But if part of your patient population are non-enrolled people, so they're not beneficiaries, then that's something that you're not going to be able to submit encounter records on because they don't have a health insurance number. But it doesn't mean that your health authority isn't interested in that, but there has to be another way for you to capture that. And so that's not a ministry issue, that is a health authority issue. So just so you know. They also establish the premiums for coverage, enrollment, and responsibilities. They approve diagnostic facilities, and they are able to audit people who are submitting services. They can conduct audits of records that get submitted to them. But again, I mean, they're paying the money, so if they want to say, we're going to audit your file to see your practice to see if you are actually providing this service, then they can do that. That's part of their mandate. Practitioner number, you all know what your practitioner number is, right? You get that when you become fully registered with CRNBC. So it's that unique assigned number. So NPs have them, physicians have them, midwives have them, optometrists have them. Lots of people have practitioner numbers. And it attaches the nurse practitioner to the encounter record that's submitted to MSP. So that's the way of tracking who's providing that care. It's also used by specialists in diagnostic facilities to get reimbursed when you refer people to those agencies. But you only get it once you're fully registered as an NP. So graduating from your program, completing the registration exams, getting fully registered, and then you have a practitioner number. You get that practitioner number. You apply for that practitioner number. And keep in mind that if you are working with NPs with provisional registration, then you are responsible for that NP's work. And so that person doesn't have a practitioner number, so that person's work would be coded with your practitioner number because you're responsible, you're supervising. They can't practice independently with provisional registration. And that was something that I recently had that question from another health authority, that they didn't understand that. So it really is important that you understand that. Also, the person who is the practitioner number that's submitted to MSP, that person is the person who's responsible for the care of that patient. So if you're working with somebody and you're doing the work and they're submitting for the work that you're doing, MSP and the government really doesn't like that idea. I know that it's happening, and there are some workarounds that are happening, but basically you shouldn't have where a nurse practitioner goes in, does the work, the physician comes in and maybe says hello to the patient and then bills for that work. It is a workaround, We know that it's happening, and hopefully at some point that'll change where you don't have to do that workaround. And this is the form. You all would have seen this form. You would have all completed this form in order to get your practitioner number. Now, practitioner numbers are one thing. Payee numbers, this is where it can get confusing, are the same number. But the payee number or the payment number is used by the ministry to, or by MSP, to now initiate payment. So practitioner number is the person who's providing the care, and then that usually that number is the same, but it's a way of saying here's how we track where the money goes. It's with that payment number. So it identifies, so the practitioner number identifies the practitioner rendering the service. The payment number identifies the person or the group to whom payment is made. Okay? So for nurse practitioners, that number may be the same or it may be different. So for nurse practitioners, if it's different, it's because they're associated with their employer number. So some of you may have completed a form that looked like this, which was an assignment of payment form. I mean, again, you have to realize that we're still operating in that MSP fee-for-service environment. So some things get used the same way, even though it's for nurse practitioners. So you may have, and I know in the earlier group, people talked about that they got this form where they had to sign it, and they had to put in their where they were working, their practitioner number, and all those things. And basically what this says is, yes, I'm the nurse practitioner working at Fraser Health, and any of my activities get assigned to my employer. And so all of the health authorities have these payee numbers. So if they have physicians that are salaried physicians or alternative payment physicians, physicians would assign this to the health authority so that the money would go to the health authority because the health authority would pay them a salary or whatever. Okay, but if you don't have when you start out, you complete that application to get that billing number, what's called a billing number. So payee number, payment number, billing number, they're all the same. Somebody's talking about the same thing. So this is the form that's completed if you're using the employer's payee number. So that's the assignment. This is the form that you use if you're using your personal payee number. And there may be situations where there isn't, we had this discussion, and Fraser Health has one payee number, and it hasn't been an issue here, but there has been an issue in some health authorities where they wanted each nurse practitioner to have their own payee number, just like physicians have their own payee number. And the ministry said, no, we're not going to assign that many payee numbers. And so the health authorities have had to kind of shift their thinking and recognize that as the employer, you can track NP activity by practitioner number and not worry about the payee number. Okay? So, moving on from payee and practitioner. Yep.
And other people's, and I put that on my lab forms and stuff.
Yep,
So
that's your practitioner number.
But it's not my CRBC number.
Nope, that's your registration number.
Okay,
Yeah.
I get it. Okay.
Yeah. And if you have, once nurse practitioners have the ability to prescribe controlled drugs and substances, there may be another number, that gets put on those prescriptions. So it's keeping track of these different numbers. Okay, so now one of the things when I started looking at encounter coding is that I had to realize that it's not encounter. What we're talking about is encounter reporting, because it's the encounter codes are part of that record that gets submitted. So the report that gets submitted. And that report is the record of services that they provide. So that's what's in the report. Each of those submissions that go to MSP is called an encounter report. It's similar to a medical claim, but there's no fee attached to it. It's submitted electronically. So some of you may be collecting these by paper, but MSP only accepts electronic submissions. So somebody takes your paper copies and inputs that data into a portal that goes to MSP. It's confidential information. It's not something that's readily available to the public. It's available to people who work in the ministry. It's available, some level of that data is available to health authorities through an agreement of what kind of access health authorities are able to have. But it is confidential information. For me as a researcher, trying to access that data, once I found, took a year to find it, then I had to submit a claim, a request for the type of data that I wanted, and there's only limited types of data that I could get, and it's aggregate data, anonymized, so anonymized aggregate data. No practitioner number was there, so I couldn't link it to anybody. I mean, you wouldn't know your practitioner number anyway, but it couldn't be linked back, so very confidential, protected. And in order to get it, then it had to go through ethics. So I had to get UVic's ethics approval, and then to be able to access it. And I can only use it, the data, in certain ways, and I have to have approval through POP data in order to publish data. So what I'm going to show you today, I have a permission to be able to use it. So again, you can see how it's protected. And none of it is patient-specific data. Yeah.
In a slide previously, though, it said that MSP could use payee numbers or practitioner numbers to audit. So that's anonymous to you, but it's not anonymous to them, right? They're storing it with our practitioner numbers attached.
Yeah, they can pull that data if they need to. Oh yeah, and again, they're the people who are paying the money, and so but that's their ability to be able to pull that data. Like in talking with the folks at the ministry, they could run a report, but they could only use that report internally. So they couldn't give it to me as an external person, but they could run it internally for their purposes. And again, they're not looking at that point, they're not, if they were looking at something like trying to do a chart audit, that would be because something was being flagged or something was coming up on payments with something's not right here. We need to go back and find out what's going on. And I make the comparison to the U.S. and Medicare, Medicaid fraud. So there were lots of billing that was happening, and so Medicare, who's the payer, said, well, we need to take a look at this, or Medicaid. And so that's how those audits would occur. Okay, so the purpose of the reports are that record. They also tell you the location, so where the nurse practitioner is practicing, the type of patient data, name, diagnosis, personal insurance number. It also allows specialist GPs and diagnostic facilities to be paid for the services that are being referred. And it assists the ministry to globally evaluate NP practice patterns and project funding requirements. Now, I say globally because, again, the ministry isn't interested in individual NP data. There's nobody in the government that says, I know Fiona Hutchinson and I want to see what's going on in her practice. That actually would be a breach of confidentiality and usage and all those other things, and that person could get in a lot of trouble. But they don't look at that specific level of data. We couldn't even look at that. If we wanted to look at NP data, we couldn't drill down to the individual NP level. So it is that. So I want you to know it's global. Big picture, not small picture. So these are the things that get included in that record. And for any of you who have seen how MSP records get filed, you know that there's a screen and there are these fields, and each of those fields need to be completed, and then you hit send and it goes off. And if some of those fields are not complete, it comes back. And so for those of you, you may be in practices where you actually can get remittance statements in your practice, so that you would know when you have rejections of codes. But for some of you and maybe for many of you, you don't see that remittance statement coming back because that's all done centrally within Fraser Health. Okay, but if Fraser Health wanted to know what kind of codes were getting rejected or what kind of records were getting rejected, they would have to take a look at their remittance records that come back, because it will tell you codes that are rejected. It'll also tell you who submitted the code because it's attached to a practitioner number. So again, it would be that level of how then the health authority could say, okay, we've got something going on with this nurse. Maybe it's somebody who's new and they don't have a good understanding or whatever because all their codes are getting rejected. Oh, I just want to say that, so in here, ICD-9 codes are part of the record submission. One is mandatory, so you need to be submitting mandatory or ICD-9 codes. Max is 3. And you need to be using the list of codes that's on the Ministry of Health's website, because those are the only ones that they capture. And if you're using V codes, they don't capture V codes. And so that's why we've made some changes with the complexity rating scale that would capture that same type of information that you would have captured with V codes. So there were people this morning that didn't, they were surprised that they couldn't use V codes. I mean, you can use them, it's just not going to be captured. And when I say captured, so if you poll that data, because there's only some things that stick, so if you're polling it, then those ICD-9 codes that the ministry has on their website, those are the ones that they capture. Those are the ones that stick. And something else that you submit, it just doesn't get captured. Does that make sense?
It's interesting though, because for instance you use profile EMR and you'll put under the ICD like V70, which is general examination, or V72.5 for women's health or PAP, and so the system allows you to just enter it, but yet, yeah, I never realized that point. Interesting.
And again, that was something that it took going through with the working group and everybody talking about, because most NPs were using V codes because that was a way of trying to capture some of that work. And it was only hearing from Val Johnson at MSP saying, we don't capture that.
So that's interesting, because I have gotten some sent back to me with something wasn't right, but I've never had one come back and say a B code wasn't right. And lots of times if I see a woman at all done for PAP, I put B72.31.
But it's not getting, it's just not sticking. So it wouldn't get rejected.
Reject it though. Would it make it rejected, or it'd have to go to the ministry and then come back to me?
It's not going anywhere. That's what I'm saying. It's not being captured.
1,000 youth clinics right there.
Exactly.
Youth clinics.
But we're going to talk about that. We're going to, we're going to stay tuned. Yes, sir.
Profile being on it, and you're right, V codes, it says it's incomplete. It tells you when you do a quick bill. But my concern is I'm supposed to put an ICD-9, and that's in that book for ICD-9. It's got nothing to do with my encounter code, but it's the ICD-9, so I struggle. Okay, what kind of ICD-9?
But they're two different things. So the ICD-9 is about your diagnosis,
Right.
and the encounter code is about what you do.
Right, but even in the ICD-9 codes, there's certain things that are not captured in the ICD-9 codes that are there. So in their list, they have the V codes, right? They're not in the nurse practitioner encounter codes. They're in the ICD-9 codes, the V codes.
I understand, but they're not in the ministry's V codes. Now, keep in mind that there are, I don't know, maybe 1 million ICD-9 codes, and now there's ICD-10. They've upgraded it, and the ministry isn't planning to upgrade anytime soon. So they've said, okay, these are the ones that we're going to use. So that's why it's important to use that list that's on the ministry website. And that way you'll see the types of diagnoses that does get captured. So if you want, and I'll show you what we can learn through looking at ICD-9 codes. So it is important, and I think for many NPs they wouldn't have necessarily known those limitations that the ministry has placed, because they purchase the use of ICD-9 codes. So if they say, okay, we don't need all of them, we're just going to buy these. And that's the list that's there.
That's interesting. I'm thinking like for contraception, I think they're all V codes. I don't know any ones that are for contraception that aren't V codes. So then what would you use if you had a clinic visit just for birth control? What do you use?
Well, it's part of your patient visit, right?
Yeah, but then you have to put one ICD-9, but if there isn't one for contraception, to just make something else up.
No, you have to find something. So again, if you were to, we won't walk through that today, but if you go into the breakdown under GU, you'll probably find something as if you need a diagnosis. So the diagnosis is what you're giving that person, not what you do with that person in the visit. Okay? Okay, so encounter codes then capture the practice activities, so the types of service that you're providing to the NP. So again, they're similar to the fee code. So again, the whole reason for these, and this is across Canada, that physicians have fee codes because it's that fee-for-service environment. So that's the environment, that's the reality. The majority of primary care today in Canada is still being provided by a fee-for-service in a fee-for-service practice by physicians. So there has to be ways of getting for fee-for-service to get for that to be paid. So that's where these codes come from. When I practiced in the States, we didn't have encounter codes, but we had ways of, we used ICD-9, I used V codes, but that was how payments were made, but that was in the U.S. That's not here. So just keep in mind that it's where we are now. And so just keeping in mind that they're not the same as the encounter codes. They have two different, the purposes are different. And there are different categories, and in the document that's on the website, so the updated one, you'll see that we tried to really have it organized in a way that makes sense, hopefully. And also, there's another version of this that's coming out in March, because I actually have gone back and tweaked it a little more, trying to provide more explanation of some of the codes that I felt like needed more explanation. So there are patient encounters where you use the complexity encounter codes. There are patient encounters where you don't use those codes. Then there are the services that are coded annually. So again, this is similar to physicians, so that complex and chronic care codes that you can only code once a year. And the procedure codes, so that's where your V codes would be. Those are procedure codes that are there that you use. And then the clinical diagnostic tests that you would perform in your office. So those are the categories that you'll find in the document. So the changes are the complexity rating scale. So the complexity rating scale came out of the work of the Encounter Code Working Group from NPs. And some of you would have been involved in maybe pilot testing the scale when we first started with it. And so what we heard through the focus groups that I conducted at the BCMPA conference, and some of you may have participated in those focus groups, with saying, do you submit encounter codes, and what do you think about them? And I didn't really hear anything good about them. But what we did hear was, from NPs, they don't capture what we do, because they don't capture the education, they don't capture the teaching, they don't capture the psychosocial stuff, they don't capture that. And so in the working group, NPs said, what can we do to capture that work in a way that cuts down on coding? And that's where the complexity rating scale came in. That's how that came up. And I'm going to just walk you through it a little bit. We've also expanded the age range. So before it was 2 to 59, and then it went 2 to 49. And then at our last meeting in November, we heard from MPs saying, it doesn't help us to capture anything for those of us who are doing a lot of youth care. And so now the ranges are 0 to 1, 2 to 19, 20 to 49, and then the next group. And you can see that it stops at 80 and plus, so at some point we may need to break that down. And then they're intentionally similar to the physician codes, and the rationale for that was there may be a time when we need to make comparisons, and so if we have it set up similarly, then it'll be easier to make those comparisons. And so we didn't want to set up something that was totally different, and trying to use it within that fee-for-service environment. And if you think about if fee-for-service environment went away and nobody was paid, fee-for-service physicians or NPs, there would still be a need to be able to track practice activities in order to generate payment, even if that payment was going from the ministry to the health authorities. And one of the things that I realized in working through all of this is that the health authorities are paid for acute care. They're not paid to perform primary care. They're not responsible for primary care. Primary care is set up in a fee-for-service environment for the most part with physicians. And there's a disconnect because nurse practitioners were originally intended to practice in primary care. And so some of this issue around funding has been because the health authorities have money for acute care and they don't have money for primary care, so they were having to take money from acute care and try to fund NPs in primary care. So there really is that discussion around how do we allocate money in primary care for NPs so that NPs get added to those providers who can, where money can be set aside to support, just like for midwives or optometrists or other people who bill MSP. So again, there are these things that as we evolve through looking at this role of what it means when you introduce a new role, who is another primary care provider, there are all these systems issues that need to be worked out and need to be changed and shifted. So that's why it just seems like it takes forever to make some of these things become apparent. But I think even for the government, there are times when it doesn't become apparent to them until somebody brings it to their attention. Okay, so I want to spend some time talking about, so what can you learn from encounter codes or encounter reporting? Because there have been NPs that have been very concerned that there's going to be this kind of oversight or government looking in on their practice and saying, well, you're not doing a good job. You're not seeing enough patients. You're not taking care of the right kind of patients, or you're spending too long with patients. Well, that is not going to tell, this data doesn't tell, won't report that to physicians or to the government. It does let you know, so it does report on access, so the number of patients receiving care from NPs. You can tell that from encounter reporting because you're putting in there their codes for new patients. These are all about numbers of encounters that you're having, and so that type of information, the age of patients, because that's part of the data that's on that submission, that record. The most common location of practice. So it asks, you have to put that. That's one of the fields that have to be put in. And there are all the different locations. So if you're seeing somebody in an office setting, that has a practice location. If you're seeing somebody in the home, same nurse practitioner, but seeing people in the home, there's a practice location for that. So that gets captured. And then the types of services that provide, the patient's condition via the ICD-9 code. Then procedures that are performed of those that are included. And if you look at that procedure list, what we tried to do, again, was to collapse the list because there were many, many things on there that actually we could kind of put those together. An IUD insertion, removal, and the third thing to do with that, or endometrial biopsy. All that is kind of, it's not the same activity, but it falls within kind of that same type of activity that you're doing. Where it gets disseminated or clarified is in the patient record. So it doesn't, there's no need for that level of detail to differentiate in the encounter record. Yeah.
I have a question that's maybe off topic, but is the ministry differentiating between NP positions that were funded earlier and NP for BC positions? No?
Now, there may be the way that the NP for BC positions were set up was that there was an expectation of some reporting around those particular positions. But again, it is that is at a high level, and maybe Pam, you could speak to that.
Yeah, not that we're aware of in terms of the the dating. I think with the MP for BC, certainly in the deliverables sections, there were those things delineated out, but a lot of those pre-existed, officially or unofficially, in the programs, in the clinical programs. But to our knowledge, there's no, I mean, you're still submitting the same way you're submitting, it's still going through teleplan to the ministries. We're not being asked for a distinction. So.
Okay, and then the number of referrals that you're making. So you can tell that because there's that 3333 encounter code that gets submitted. So you can find out that type of information. So it's not patient-specific information. Doesn't tell you anything about patient outcomes. Doesn't tell you how many emergency department visits that have been that you've reduced. Doesn't tell you anything about hospital admissions. Doesn't tell you anything about that because that is patient-specific information. That information can be obtained through your EMRs at the health authority level, but not at the ministry level from your records or from physician records.
Just about referrals. That's still the only part of this that I'm having struggles with. So, I'm not submitting electronically, and I realize that people who are submitting electronically have some field that when they refer pops down on their screen and pops a list of all the providers, and they select the MSP or whatever for that provider that they're referring to, and it all goes through the electronic. But when we discussed this before, my question was, I don't have that list at my ready, right? I'm flying from place to place without any electronic record, right? So for me to go and find an MSP number of person so-and-so that I'm referring to, it's not very practical in the moment for me to be able to do that. It would be quite a bit of time, unless, of course, my clerk was able to add that on to her long list, but it's probably not going to happen. So anyway, when we talked, my takeaway was that for now I wasn't going to worry about referrals because I'm just not doing it electronically, and so it's not going to kick it back to me. But it obviously wouldn't be collecting any referrals that I'm making because I'm not putting anything in for that.
But if you're referring to other providers, so to specialists, then somebody has to put whatever is required in for that referral?
Well, his secretary is putting it in at the other end.
Okay.
But, like I say, I'm referring to so-and-so spec cardiologist. I have my page that has my number on it, and my story about why I'm referring goes to his office, and his secretary puts in my number, and puts in his number, and gets paid.
Right.
But I'm not tracking that information.
Yeah.
So, I know he's still getting paid, but...
Yeah. But he's getting paid because he's using your practitioner number.
Exactly. But I'm not selecting his practitioner number from any list and saying, this is the guy I refer to on Tuesday.
Yeah. And I would think that probably is happening in most people's offices because it is who is going to take the referral, and so that's probably a clerical duty with making sure that. But the main thing is that your MSP number goes with it, because it's your MSP number as the referrer.
So someone's collecting that those referrals have been made. It's just not going to show up in my.
Well, I can tell how many how I can look at how often that referral code is used. So 3333. I can tell how often NPs are using that code.
Okay, so I just am not sure what the 3333 is. Is it a?
That's the code that you would use when you're referring somebody, and it's occurring outside of the visit.
Okay, outside of the visit. So what do you mean it's occurring outside of the visit?
It shows up on medical record. No, I know it shows up, but I tend to use that. I tend to just use a complexity scale, and I don't use the MSP because it's too cumbersome to find a profile, who's who. I generate a letter, type it up, give it to my MOA. She does what puts on a sticker to whom it's going to go to, and it goes. And I do not put on a separate quick bill for referrals. That's what we have to know.
Yeah, and no, because it's occurring within the visit.
Even if I'm doing it afterwards, on the side of my desk, the visit's done, I don't tend to code separately because it doesn't show separately on my appointment calendar, so therefore I tend to just put it all in lump sum.
Yeah. So if you're not getting, I would say, I wouldn't worry about that too much, because if the specialists are getting paid, then there's not a problem. And you would know. Well, and NPs knew because originally when NPs started referring to specialists, they weren't getting paid. And so you had to educate them that they would get paid.
But just so I understand the purpose of 333. So, whatever. So, like you were saying, in the complexity code, sort of captures if you're having to do referrals. But I understood that you can only do one code per day, encounter codes for that patient, unless it's a separate visit. That's what we talked about before. I don't know if that's correct, but if I just saw Nancy and I put in my visit, complexity code, whatever, and then later that day I would sit down and do her referral, and I can put her sticker on the paper again on the same day and say 3333?
This would be, you decide 2 weeks from now to do that.
Okay.
And it's not attached. Yeah, and so, yeah.
On that same day?
Yeah, so most of the time it's attached to that visit.
So most of the time, if I'm seeing the person in the visit and I'm deciding I'm going to do a referral, and I go later that day and write my referral,
Right.
I'm not deciding it way later. So then, it would just be captured in that visit complexity code,
Yeah.
not with a separate code, because we cannot submit more than one encounter per day per patient, right? Okay.
We'll talk about that. We'll talk about that. So there is, if you are submitting, why would you submit more than one code a day for the same patient?
I did a PAP and I also did I did a dressing on her. Those are 2 different encounter codes.
No, they're not. Did she come back? Okay, so it's one encounter.
It's just a complexity goes up per
But no, because I'm just doing PAP, that's one different encounter code. There's no complexity in there. But if I'm doing a bunch of things, I could put 2 encounter codes in.
So it's what I heard you say was that you're submitting multiple records for the same patient in the same day.
So if I did, I hardly ever do it usually, but if I'm doing something like a gynae, that's a certain thing. Then suppose I did chronic disease management as part of the same visit, wouldn't I put 2? How would I pick which one would I do? So sometimes I might do a yearly visit about diabetes as well as doing a pelvic exam. I can't put them both in?
Yeah. I mean, so again, you're capturing the activity that you did, and your pap smear would be captured under, I think it's captured under a procedure code.
But that's changed to encounter
That's
codes.
okay. That's okay. Yeah, because you're presenting, you're including an encounter code for the service that you provided and a procedure code for the procedure that you did.
Those aren't considered one codes. That's where the mix-up is.
What's
Yes, I
that?
thought they were all different. I
Because
thought that was 2 encounter
for
codes. Then
example-
one's for gynae, one's for, like I don't usually put down a clinic visit and a procedure code. I put either or. Like sometimes I might see someone in the clinic, I'd only put down that I did chronic disease management. I wouldn't put down that she had a visit as well.
Yeah, so I think that what we're trying to do is, and we'll talk about this with the complexity rating scale, because what we're trying to do is capture that work in one encounter code.
Right. So then you have to pick, because sometimes when I see someone for diabetes, it can be very complex. It might take me a half hour, because I did a lot of stuff.
Okay, but you have to look at what codes can you code only once. So there are, and again, this is where it parallels with physician. So annual visits for complex care visits, that's once a year.
Right.
So you wouldn't code that all the time.
No, but say with the 1 year, the once a year that she comes in, I have had this happen where I have someone who's diabetes and I do her once a year visit, and included in that I also do a pelvic exam because that's part of the full physical exam. So I would put I don't remember, 363, 33 or whatever it is, and then the complex care for diabetes. So is that okay to put both those encounter codes in?
So the procedure, let me just look under procedure codes here.
Encounter code?
Yes, but it's a procedure code. It's coding a procedure. Okay, so you have to think of,
So what would,
They're separated.
okay,
So there's a procedure code.
I'm just recognization and, okay.
These are different.
Oh, okay. So under gynecological procedures, routine pelvic exams, including pap smears. That's a procedure.
Right, so I could add that on to a visit code as well?
Right. Yeah.
As well as the chronic disease code?
No.
No, because that's different. Okay, I'm really confused here.
Yeah, so you have to take a look at this because it goes in, like I said, it shows you those things that you would use all the time, which are basically the complexity rating scales, and then those things that can only be coded once a year. So those are the chronic disease management visits where you're bringing that person in and you're wrapping up everything, you know, taking a look at medications.
Add those to a clinic visit. But you could say you could have her come in for a clinic visit about her diabetes. It wasn't the once a year thing, and add a pelvic exam.
Yes.
Okay, well,
Yeah,
And it would show up in your ICD-9 code because you would ICD-9 code your diabetes.
right.
It's similar to, sorry, like if you somebody that's coming in for diabetes, hypertension, then you get the tetanus shot.
Yeah.
Then you get the flu
Right.
shot.
Yeah.
Right.
So same thing.
Yeah,
Same thing.
yeah. So it just helps to capture the procedures.
So I think there was two other questions here. Did you have a question?
Okay.
There was something on this side that had hand
The only gap I see with the coding is sometimes you refer to a group of doctors and then they assign it, and you can't capture that because you're not putting the name of the doctor in one.
Yeah, but somebody is taking care of that so that that physician gets paid. So I wouldn't worry about it. It's just if you're getting rejected for some reason.
One more question. I do very complex care in my clinic, and then I do home visits. I'm always wondering, okay, which one is going to capture that I spent 2.5 hours in this house, doing all this care? Is it going to be complex care, or is it just home visit? If I just put home visit.
So home visit is the location of the visit, okay? So that just tells you where you did it. So you can use complexity codes in the home. So if you look at,
I'm trying to figure that one out.
well, if it's something that, say most of the time, or you routinely, I mean, you have to read the definition for what the home visit is here.
I only see them in their houses.
Right. So that is the practice location. That's where you use the code here for practice location. Because then that says, I'm taking care of this person in their patient's private home.
So therefore, because
That's
that's a
an
different
R.
number.
No,
so
it's an
then
R. No, it's just a designation of practice location. It's not.
So that's a number that you're putting in
Right.
to say that it's a home visit.
Right.
So now I will have to put in another number
Encounter number.
for complexity.
The encounter code.
So that's where this is so confusing. Like you're calling everything encounter, but then you're saying this is separate. Then this is separate.
Well, and that's why I'm saying it's an encounter record. So it's a report. It's a report that has all these pieces in it.
I understand that, but I just wish there was a way to kind of separate it with different word. Because if this was a procedure, I get it now. I get it. This is a procedure. You can add it to it. But it doesn't explain it because these numbers all start with 3636. So it's really difficult to know, okay, have I had done my one for the day, or am I going to add this in?
But the location code is only one number. It's like mine is number 9.
It's a letter.
It's a letter, whatever it is. It's not, it's a location code. It's completely separate from the visit code.
Yeah. So that's why we have this as something to get very intimately acquainted with, because we've tried to say at the very beginning, so what's included in that record submission? And that's why I said encounter records are more than, encounter codes, they're more than just encounter codes. The code is one piece.
I was just thinking, if I did a pelvic exam with someone, I really don't need an ICD-9 for the pelvic exam because it's already covered under procedure code.
Right.
Okay, so if someone came in for a pelvic exam, I could put pelvic exam and clinic visit, right? Because then those two would capture it, and don't forget the ICD-9.
Well, you still need a diagnosis. Why are you seeing that person?
Because they're healthy and we're screening them for.
Okay, so then you'd have to find the ICD-9 code that matches that. So that's why it says that they all, anytime that you're submitting a record, there needs to be an ICD-9 code attached, a diagnostic code, because you need to have a reason for seeing that person.
That I think what hangs us all up, like so this is how I was feeling too at first, is like our level of detail that we think is required for this is, in my mind, we have way higher expectation of the minutia that we think we're supposed to put in this. They don't care about the minutia. They just want the big picture overall. So you might not find the exact ICD-9 code that matches. Like, I can pick for heart failure about 5 ICD-9 codes. Okay, I always pick the most general one, and that's what I use every time, and it's always the same. And it really doesn't matter. You're just trying to get the ballpark of what you saw the person for. They're not going to go, you said you saw them for exacerbation of CHF, when really you just saw them for heart failure. Whatever. They don't care.
Yeah, yeah. Nope, that's okay.
But getting back to the just one encounter-coded day thing, so I don't think I've been doing this correctly, so lots of times I'll see one of my frail seniors, and then that just sets off a flurry of other things in terms of phone calls to various healthcare people and family and whatever. And I lots of times do that on the same day, right? Because I want stuff, it feels like it has to be urgent. So I wouldn't code. I have been coding like telemanagement visits and possibly whatever, as well as a complex encounter code, but I shouldn't be doing that because it's all part of the complexity.
Exactly.
It sounds like, so I have not done a lot of encounter coding. I haven't had the opportunity to have that ability in my clinical practice right now. But it really sounds like there's a difference between the record, which I think of as like a form that I would fill out for every patient I see, right? And on that, I would fill out one code for what I did with that patient, one ICD-9 up to 3 for their diagnoses, and it sounds like there's a code specifically to label how complex that visit was.
But that's the code you're using.
Right. And all the other stuff around location, although that's like the header of your form, essentially.
Well, it's all, if you think about that, it's all of that's in the form.
Right.
So
But
those
it's
are
not
those
so
are
much
places
that
you
we're
need to
talking
fill
about
in.
encounter codes. It's an encounter submission.
Right.
Like
Right.
each. Okay.
Yeah, that's why they're called encounter
Right.
reports.
And you only submit one of those submissions once a day. Would there be a time where you would submit more than one? Let's say a patient leaves and then phones 4 hours later and says, this has happened, blah, 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 and you do a tele-visit. Would you submit
If it's
that?
something that's totally unrelated to what, if they call and say, I just need some clarification, you said this, but I don't remember. Well, no. But if something new happened, and I think in acute care or residential care, you may see that person and you get them all wrapped up, and you may go back in and out during the day because you're following up on what you needed to. Same way with residential care visit, where you need to follow up with the staff and get results of lab work and those kind of things. And you've done all that, and that's all one visit, considered one, it's just that continuing. In acute care, sometimes you make multiple visits, but now something new happens.
Totally different.
Yeah, so now you need to go back and start over again. So that would be a reassessment visit, because now it's something new, unexpected.
So even in the outpatient, it happens to me all the time. I see a person, they haven't gone for their lab work. I don't know their lab work when I see them
Right,
at that
right.
visit.
Yeah.
I don't look at their lab work after it comes back. And I see there's something, out of whack with their lab work. That's still part of that visit, because that's part of that visit. That's what I was doing at that visit.
Yeah, and one of the things, you bring up a good point with how to look at lab work. So, because sometimes that lab work, you order that, and you get a stack of lab work that comes back, and now you have to spend time looking at the lab work. And I would say that that's not recorded. That activity isn't recorded in an encounter code, but it is part of your work. And that's what you negotiate with your manager to say, I need to have set aside X amount of time every day to return phone calls, look at lab work, all of those things, because that's still part of your work, but it doesn't get captured in an encounter code. Okay? So that's how you negotiate for that amount of time that you need to look at those things.
So you send somebody for testing on a Wednesday and you get a result on a Monday that's positive, warranting the need to initiate antibiotics. That wouldn't be a new visit then? Because
Well, are you bringing that person in?
No.
You're doing telephone.
Telephone.
Okay, so you've got a code for that.
That would be a new
That would be an encounter code. You would use, that would be a new submission that you would make using that telephone call, telemanagement, whatever, as the encounter code.
So one thing I wonder, so supposing, why if it's another day can you claim it any different than say it was 4 o'clock that day and somebody came back, even though it was related to what you saw them, but you had to do a bunch more work, like maybe you had to call them, you had to call the pharmacy, you had to do prescription and stuff came up. If it was the next day you could claim it, but if it was on the same day you can't.
If you think about, again, I think that it is, you've got somebody that you see today. So this isn't me that says, no, you can't do it, but the ministry, then you would need to justify, if you think about, keep in mind, these codes were created in a fee-for-service environment, so what part of that would warrant another payment versus what part of that is really just continuing on because of what you did earlier?
I would think that if whether it's today or whether they didn't do the lab work till tomorrow, it would still be part of that same visit, really, technically. If it's
Yeah, I mean, that's what I'm saying, that when you're looking at lab work, there's some lab work you'll look at, a whole stack of lab work, and everything's normal. So you don't worry about that. But that's part of your time that you need.
I may be making an assumption here, but often in a fee-for-service model, that's why they don't give you results over the phone.
Right.
That's why they say, come back to my office
Exactly,
and talk about the
exactly.
results. Because now I can bill for it.
Yeah, yeah.
And really, it's kind of minutia again, because they don't really care. Did you see this person this day, and then this day, 2 days later? They just care generally how much we're doing, what we're doing.
I think it does make a difference because sometimes when you're saying that I've only seen 3 patients, you've only billed that complex care 3 times. Meanwhile, you spend 7 hours going through the chart and calling the pharmacy, calling this and that, home care. It doesn't get captured.
But it doesn't need to be captured by the ministry. It needs to be captured between you and your manager. So if you're spending 7 hours on one patient, then if I'm your manager, I'm going to say, gee, Carol, tell me. Exactly. But that's between, yeah. And that's between you and your manager.
I feel guilty because I go, well, if you were to pull up my data, you're going to say, what the heck, she was sitting on her ass all day? Like, you know,
But that's what I'm saying. The ministry isn't concerned about that, because the ministry says, I give you Fraser Health X amount of dollars to hire NPs. And it's up to you to make sure that those NPs are doing the work that you hire them to do. Just like they give X amount of money to hire X number of RNs or LPNs or whatever.
Older NPs, it's because when these first came out, we were always told that the government was monitoring us based on these numbers. That's where it's coming
But
from.
I think now, but what they did, they looked at my data, printed it, and they thought, okay, something isn't being captured. This is the management. You know, we're all
Right,
sitting
that's the
down,
management. That's
right?
not the
What's not
ministry.
being captured? What wasn't being captured was those telephone calls I was making. What wasn't captured was when I was reviewing the chart reviews, talking to them. So now we put it in our, the morning appointment book.
Yeah.
Telephone calls.
Yep.
So now they're capturing, so that's okay.
That's why management now you're hearing from management saying don't leave your schedule empty. You have to have it
What are you
filled in.
What are you doing?
Exactly. We're hearing that from management versus the ministry.
Okay, so that's why
Yeah. So, and that is excellent, because it's not the ministry that's monitoring, but your manager. I mean, you're accountable. You're an employee, so you're accountable. But that's the discussion that happens with you and your manager. Karen?
Well, I think part of me too worries, because I know the ministry is monitoring the number of, like, they have a new telemanagement fee for GPs, right, through the new initiatives that they're doing through the divisions now. And it is all about that. They are monitoring it.
Well, no, it's about physicians wanting to get paid for the work that they
But they're
do.
also monitoring their success and how often they're paying out this. They see that as a success because it's increasing patient access, right? So they're looking at that. So that, and the chart review code that the physician has, right, for the type of work that you're talking about that we just put into our schedule. There's a payment involved there. So when I'm in an office of GPs and various providers, the MOAs are actually, they're taught to get the max out of their billings, right? So they're coming to me and saying, why aren't you coding for this? You should be coding for a chart review. You need to find out why you're not getting, you don't have a code for a chart review anymore, right? And it makes me nervous to think, that is my practice. That's my practice pattern. It's not showing up.
Yeah. And again, this whole thing with, keep in mind that, the whole purpose of the BCMA or Doctors for BC, their whole purpose in life is to get money for physicians. And so if you look at, that's their union, right? And that's their job, and they're doing a very good job of it. But what it means is if you look on their at their codes and the explanation of those codes, it really is about how can they get paid for doing all of these types of things that if they were employees, then maybe they wouldn't need to capture all of that. But because everything they do needs to be tied to a dollar value so that they can earn their income. You, on the other hand, are a salaried employee, and part of that is saying, here's your salary, and for this, and you're expected to do these types of things.
But in a way, it's lost work that we're doing, and because we're doing very similar to what they're doing, but we get a fraction of the amount of money they get, and so we look like a lesser service.
That's the worry
That's the worry, because they push what you have to have.
Okay, let's talk about So let's talk about what you can learn through encounter coding. Okay? Before I move on? Okay.
Yeah, I'm just conscious of the time, because
Yeah.
she has to leave at 3, and it's 2.
Yeah. Okay, so this is the NP encounter code data that I looked at, and I was able to get data from 94 different NPs and 470,762 data points. So all of that gets dumped into computer software program, SPSS. And you can see how each year, so starting in 2005, there were 4 very dedicated NPs who started submitting, but we didn't have a lot of NPs in 2005, rather. And then that number has gone up, but then we get to a high point in 2009, and then they start to go down. And some of that was NPs saying, I don't know what's happening to the data, nobody's telling me anything about it, I'm going to stop coding, I don't have an EMR, it's all paper. I keep all my, I've had NPs saying to me that I keep all those encounter codes in a shoebox under my bed because someday somebody's going to want them and I've got them and, whatever. To me, the issue is we need to get all NPs with EMRs, but that's another point. Okay, so then in looking at that data, so here was the top 20 care activities that NPs were submitting encounter codes for. So office visit for that 2 to 59 age range. So that was, that's a big section of all of those age ranges. So that's where the majority of people were spending that time. And then you can see information provided, education materials, therapeutic communication, individual counseling, education on unhealthy lifestyles. So those were all the different encounter codes that were out there. So then if you look at this, if I'm looking at this and I say, a lot of that an RN could do. Okay, nobody said that at the ministry, and I haven't said that to the ministry, but a lot of that, if these are the most common top 20, then an RN can do a lot of that. But it's also part of our practices in PEDS, right? So then I said, okay, and I had a research assistant who was helping me with this, and I said, okay, some of those things, let's look at that in another way and look at what are the most common practice activities if we took out the procedures that were in there, because some of those were the pelvic exams, the intramuscular injection. I mean, intramuscular injection was like pretty high here, so pretty high up. So I took out some of those things that were procedures. Let's take the procedures out. So then, what are those most common activities? So again, a lot of that came up were around the counseling and communication. But also, the office visits, the different age ranges, whatever. So you can see that most NPs were using that 36301 for their encounter code and probably weren't coding anything else but that. So then I said, okay, what are the most common procedures? Well, injections was first, and pelvic exams were second, and then cryotherapy. So those were, we just kind of collapsed them and said those most common procedures. So then I said, what were the most common ICD-9 codes? So what were the most common ICD-9 codes? So the yellow is giving you some of that highlight, and then the age range. So some of the things that I could look at that and say, okay, NPs are seeing people with essential hypertension. They start seeing them in 2 to 59, but look at that. As the person gets older, then there's more that are being treated for hypertension. So that tells me something about that patient population, that age group with chronic renal failure. Don't expect to see that early, and so you're not seeing it, but as people get older, the more likely they are to have that diagnosis. Okay, so those were the types of things that I could tell about that, about these different ICD-9 codes. So those are the kind of things that you can tell about NP practice. So then, looking at age ranges. So and again, this was before we've now broken down that age range. So the majority of NPs are seeing people in that 2 to 59 age range. But they're seeing some people, some pediatric people, and as more codes were submitted, then the numbers for all age ranges went up. So then that tells me that nurse practitioners are seeing the patients of all ages, which is what they were expected to do, and they're seeing people with complex care problems, which is what they were expected to do. So that gives you an idea of what the ministry can learn about your practice. So what it doesn't capture, what they don't capture, would be those physiological monitors. So how well is diabetes controlled? Well, in order to know that, we actually had the dream that we'd be able to look at this until we very quickly found out that, number one, you can't get that you can't drill down that narrowly to get access to patient data, and that's what you need. That's what I needed as a researcher. I couldn't get that, and for some of the data, even if I could get it, it would have eaten up my whole grant because it's really expensive to get this as far as researchers go. It doesn't tell me anything about patient satisfaction. It doesn't tell me anything about the quality of care. But if you want to know that in your own practice, you can find that out. That can be found out within the health authorities by looking at that patient data. So if you're taking care of populations of people and you want to know the managers within Fraser Health, if they want to know, we've just hired a nurse practitioner to take care of people with heart failure. And we want to know if we can keep those people out of the emergency department, if we can keep them out of the hospital, and we can shorten their length of stay. Well, that could be found out, but that's patient-level data. That's not high-level data. So you would have to track those patients by their patient insurance number over time, looking at before the NP was hired, what was that? What were their admission rates? How often were they going to the emergency department? All of those types of things. And then track that over time to see if you saw any decreases. And the ministry isn't going to do that. So they may ask health authorities to provide them with that information. But that's where it would come from, would be from the health authorities. Okay, so let's talk about the complexity rating scale. So again, this started, nurse practitioner said, we really need to capture this information because we want to capture the the education, the counseling, and all those things because they're important. They're important to us. They're part of what we do. So we wanted to, again, try to accurately reflect the types of services that nurse practitioners were providing, and we wanted to reduce the time that you would have to spend coding. So before it was you code for the exam, you code for the education, you code for the procedure, you know, and that's what we heard from NPs. And then also reduce the number of codes for each encounter that was submitted for one visit. So the complexity rating scale is used to assign the level of complexity of the encounter with the patient. So the patient visit. How complex was that visit? Not how complex is the patient. Okay? There are 5 categories. So again, looking at trying to capture that. So the health and social history, including the review of systems, physical exam, education and counseling, psychosocial issues, and then the coordination and level of decision-making that's required. So all of this is part of this piece that's on the ministry website. So depending on what's going on, what you had to do in that encounter, we had the discussion this morning with, so what about if somebody was, you know, they didn't just, you know, they weren't just clean all the way across here, but there were some in level 1 and there were some in level 2 and there were some in level 3. Well, it doesn't take away your judgment. When you're seeing that person. So where did you have to spend the majority of your time? Was there, yes, they have multiple comorbidities, but today it was relatively straightforward because they only needed to get a refill on their medication and everything else was stable. So maybe that very complex patient is a complexity of level 1. But then 2 weeks you see them, and now they have a urinary tract infection, and they're having some confusion problems, especially if they're in residential care, whatever, and you're going to try to avert them going to the emergency department. You know, so what is it that needs to happen there? And now maybe they're a 2 or 3. So one person, one patient, can go up and down on the level of complexity of the visit, depending on what's going on with them from one time to the next. So that's where, Sue, with what I was trying to say with you, where you begin to look at what's the reason for the visit and what do I need, and do I need to spend a lot of time over here? And there are people who have complex social issues, but if you're spending most of your time here with your patient population, then I would be having that conversation with the manager to say, maybe we need to have social work involved, because if this is where you're spending all of your time, then there's probably there's a mismatch with what you should be doing and who else can do this, and recognizing that if we think about working interprofessionally, the expectation isn't that the NP would do everything. And if that seems to be an expectation within your practice, then maybe that's a conversation you have with your manager. You're smiling.
Have you seen the job postings?
Well, I know that.
Solve the world.
Yeah. And that really is important because, you know, I think about how there are times when I think we need to shift this thinking because nurse practitioners were never meant to take care of the most complex, sickest people. But because, again, of the fee-for-service system, this has been allowed to happen. Yeah, and I know, and to me, I mean, it really is how this seems to have evolved, and again, because it's driven not by who's the most appropriate provider, it is driven by who has the most time. And so because NPs are salaried, then there's this perception that you can sort through all of this, and that and it's working. I mean, the reality is it's working. But that wasn't the intent. It was never the intent.
But it's also being driven by dollars, too, because we're a cheaper dollar.
Well, it's being driven by the fee-for-service model where the more you see, the faster, then you can earn your income. And if people need a lot of time, the system doesn't allow. So it's being driven by a system.
No, but it's Fortunate because they've added more money to that system that's taking more.
And it's a piecemeal system.
I know, and it just feels like it's a backward thing. I think that's very discouraging for us because it feels that the job that we are doing is not valued as much because they've decided to give it to the doctors and give them more money for it.
You're up against a very powerful machine. And that's where the support of the health authorities to demonstrate that value is important. And that's where demonstrating that value within your practice is important. And having those conversations with your managers and all of the health authorities saying, okay, here's what we're seeing, and having that communication with the ministry to say, give us more money, put some money in primary care for NPs, so that we can continue to provide primary care services, because here's the value that's being added. And I know in my research, so the values that I was able to say to the ministry that nurse practitioners are adding to the BC healthcare system is increasing access to care. So more patients being seen because of nurse practitioners. Patients are satisfied with that care. They're changing behaviors. They're, exercising. They're taking the medications. They're losing weight. They feel more in charge. And those kind of things may sound minor, but they have cost savings over time that's tremendous. So it's one of those things, Ginny, that I would say don't get discouraged, because it is the government is always trying to accommodate and placate and work within a system, a model that really is a piecemeal model. And they keep tacking on to that piecemeal. Carrie?
Yeah, so part of the problem when we're talking about job postings is the NP for BC funding is fully intended to deal with those complex populations, right? The priority four. So, one of the questions that I wrote down at the beginning was, what do you know that the ministry is going to do? You've told us what they can understand with this codes, but are they going to even make an attempt to understand it? What have they said they're going to do with this information in terms so that they can understand their practice patterns and can understand funding requirements? Are they going to do anything?
Are they going to do anything? So what would anything look like?
Just evaluating the data and taking a look at it.
Well,
do you think that they're going to do that?
I've done that.
You've done it.
Well, I did it, but I'm working in partnership with the ministry.
So you'll be doing it ongoing?
I don't know.
Well, somebody will be.
I don't know.
Yeah. Because if we're talking exactly about what the practice patterns are and what the funding requirements are, that's what this conversation is. And if we believe that we can get that information out of this data, then one would hope that they would actually look at it now that you're involved to make better decisions next time around and be able to see it.
Yeah. But again, some of that is that discussion that goes on at the ministry level and the health authority level. So the health authority has that responsibility also of reporting to the ministry based on what's happening with the NPs that work in those different health authorities.
Because in regards to the NP for BC, it's the health authorities that put the submissions forward. So it's actually the health authorities' responsibility in regards to they were the ones that created those initial positions.
Yep. So the health authority said, here's what we want NPs to do. Give us the money, and we'll have the NP do that. So then the ministry says, okay, I gave you the money, so how's it going? They're not going to the NP to say, how's it going? They're going to the health authority to say, how's it going?
This is a long conversation, but let's face it, the proposals were aimed, they had to be aimed at the four priority populations. You couldn't just say, I want to start up a nice, regular, full-service family practice clinic, NP-run clinic. No, it had to be...
Because those are priorities. Those are the ministry's priorities.
I know, but I would just...
Yep.
That's
Yep.
my point.
Yep.
That's why we're working in those environments, right?
I think that the thing is that there's a certain amount of angst on my part anyway, and a feeling of a little bit of distrust in, how things have rolled out over all of these years with MPs and the slowness of them, of hearing about whatever work was going on with previous encounter codes. And then the fact that, like you've just alluded to, we look at the way that encounter code is from the previous data, and it doesn't look totally like it needs to be MPs. So the worry is that whenever there's data in the world, some nefarious person or system or organization that shall remain nameless might come along and take that data and use it for their own, maleficent purposes. And so that's why we're all kind of going, right?
Well, that's like the two-sided coin. You're going to have a positive and you're going to have a negative. So either you can look at it as supporting you, or you can look at it as not supporting you.
And the other thing is, when most of them come up with the highest one was the clinic visit, age 2 to 59. Lots of that work an RA couldn't do. Like what we're seeing people for, like I think when I'm at walking clinic, that would be most of my things. But an RA couldn't look after.
That is between you and your manager.
Yeah.
That's not between you and the government.
Yeah, but I'm just saying that you can take whatever data in this whole entire world and spin it whatever way you want. And I'm saying that there is two sides. Yes, we feel anxious because of that. But yes, we can also refute that with various other means. And we all have the ability. Yeah, but that's what we have to advocate for. That's what Esther's saying, advocate for with our managers and with our health authority to be able to do that. I mean, I can tell you. Well, it depends on, what your support of your manager, and that's a whole different issue, right? I mean, in heart function clinic, all we're doing is evaluation of the program, right? That's all we ever do in our programs. So there's a situation where that's working well. I'm not saying that works for everyone. I'm just saying we all have that need to advocate for that and to, advocate against fee for service.
We're meant to advocate for our patients, but we have to also advocate for our self-care profession too. So that's when we start coming to our group.
It's just that we don't have much of a power as a group because we're lost within the system, and it is a bit concerning for the future, for me personally, for the future of our profession.
The work that Stan, our leader, our president, he came to the department meeting for Fraser Health, and he did a really excellent presentation on the things and the differences that he's made so far. So if we come together as a collective group, we are a stronger voice too. So if you can advocate at your own level, but also in a group level, you can make a difference. It might be it might be a more challenging, but eventually there will be change in some form. It might be little, but it adds
Well,
up.
and you've got your communities of practice within Fraser. You now have how many? Yeah, and you have 62 NPs, maybe more than when we first started. So you're beginning to get numbers, and I would say have that discussion within your group to look at. So what are some of the things that we want to capture?
And we're at the grassroots, so we can actually maybe make a change in the way we want it to.
Yeah, and lobbying with the directors. I mean, that's one of the targets and has been to help target the directors. So because they don't report to managers, they report to directors, and so that the directors are aware and on par with. And there's some variation there. There's much to be done. So, and even just having the department where Stan could come and have that conversation.
Well, the department's agreed, for sure.
Yeah, I mean, think about, 5 years ago, everybody wanted a department, and it took a while to get there, but you're there now.
I think some of the fear comes from that historical, but potentially being compared side by side with fee-for-service positions, especially when you're looking at quantitative data. Our quantitative data will not stack up to a fee-for-service position. Because, and the fact is, and this is where I think some of this animosity and frustration comes from, is that many of us are in positions that are just ripe for burnout and are very complex and that's like you said, all we deal with is complex patients. Meanwhile, the physician gets double or triple the salary that we make, and they're sitting there doing earaches and pap smears. And that's what makes me afraid of quantitative data is that they put us side by side with physicians, and then they say, you know what, physicians' assistants could do all of this stuff for half the fee of an NP, plus all the money we're paying it. And like that, I think it comes at that distrust of being left out of those decisions, being left out of those tables, and like you said, Esther, like the idea for NPs was to actually increase access for the general public to primary care. And what's happened is that we've actually taken on the really highly complex primary care. And are being paid half the salaries you're doing. So, and I think it just comes from that background of distrust.
So
What is data?
I just want to say that we're kind of veering off with what we can solve here, or the purpose of this, because I hear your frustration, and I know for some of you it's been long-standing frustration, but probably there are myths out there that need to be we need to do away with the myths, demystified, or whatever it is. Anyway, and so some of that with comparing head-to-head NPs and physicians. I mean, you wouldn't compare, if you look at practices, so if we're going to do that, then we would need to look at practices that were comparable practices. So not taking people who have, very complex health problems and comparing those to somebody who's not taking care of those, or thinking that the only indicator of success is volume. I mean, everybody knows that's not an indicator of success. I mean, if you look at the Surgeon General or the Auditor General a couple of years ago came out with a report saying the ministry isn't trying to validate looking for quality among physicians, and there are millions of dollars that get spent on primary care, but nobody's looking at that. So there's a long list of things that need to happen before the ministry would begin to look at trying to compare NPs and physicians. So you may have the BC Medical Association saying that, but that would be to stack things to their advantage. And again, that's their role, that's their job, that's what they need to do. But then it's nursing and nurse practitioners, that's our job, to keep putting out there other confounding information. And so that's where, through your department, working together, demonstrating what are those outcomes that are happening as a result of these populations that you're caring for.
So we have about 55 minutes before we would wrap up. So were there specific things, questions for Esther, or more information?
Yeah, I just want to walk you through. These are just the website, and just so that you know, the website, the look of this website is going to change. But right now, where you'll find the encounter codes, this list that hopefully you've downloaded already, it will be revised, basically with breaking down those the age ranges, and I've gone in and added a little more definition to some of the codes. But again, this is, you may go on there one day and it's totally different. Just, we know they're changing it. And then using this list of diagnostic codes that's on the ministry's website, it's important to use that. Contact information, that's not going to go away. So you can still, that's the number if you've got questions about rejections or whatever, the MSP number, and then the email for the NP encounter codes is still that one that goes to Carla Biagioni at the ministry.
And that's on the website?
Yep.
Is there been any discussion with the ministry in regards to sharing of that information back to the individual NPs? Providing to them?
I've asked that question, and as far as I know right now, what I've said is see if you can get that, but it's not straightforward to give that individual information back, and there's not the manpower at the ministry. So you think about, so if there are 300 NPs and everybody wanted an individual report of their practice, that's probably one of the things that they would need to go in and pull the data to get that. And at this point, there's not that will to do that.
You could probably do that on your own profile if you have
Yeah, and you can, yeah. So within your own EMR, if you have an EMR, so that's why it's important for NPs to have EMRs. But that type of information, you can obtain that. So how well are your diabetics controlled? You can even find out if you've had decreased numbers of ER visits by looking at the patient data, and you can do all of that internally within your practice.
Just go to profile.
Yeah, no, I was just, I know that.
Yeah,
I was just
sure.
asking because originally, I think the first or second group, we actually did get some feedback from the ministry.
We got it once.
And then since that, we haven't received it.
What types of patients we're seeing, what conditions we're seeing.
And again, I mean, I think about the people on the ground at the ministry who's doing a lot of this type of work. are pretty thin. I mean, when we talked about the website, there wasn't any money to come up with revising the website, which is how I got involved in revising the website, for this work with encounter codes. There wasn't any money to do this. A lot of this work I paid for through my grant.
I have a couple of questions.
Okay.
There's non-Fraser Health NPs where I work. So one of the questions would be around payee numbers. So if you have multiple employers, I don't know, maybe that information is on the website. I didn't look for it there. So can you have multiple payee numbers then?
No, you have one payee number, but you would assign your payee number to a particular employer.
Okay, so
I mean, think about locums, people who do locums.
if you work for different, like if you work for one employer 2 days a week and another employer 1 day a week, how does that look?
If you're submitting, are they submitting under their payee number or their employer's payee number? So they would.
We don't have our own payee number.
Well, you do have your own payee number.
We have a practitioner.
They're the same number. But remember I showed you the forms that you would
It's only
complete?
the health authority then that has a different payee number.
Well, physicians have a different payee number. Yeah, so depending on where they're working, if they're working with physicians, then it may be that that clinic has a payee number attached to that clinic. So the nurse practitioner would need to assign their payee number to that, so that so it gets reported when the nurse practitioner's practitioner number is submitted. Then that gets recorded with where that NP is practicing based on that payee number.
Somebody else, somewhere else, she has to use her own payee number.
Well, it depends. I mean, you can assign it to more than one place.
If it's attached to billing, the physician clinic would work to attach that payee number somewhere else.
I don't know, Carrie.
They'll have to ask. They'll have to ask.
Yeah.
So consultative work. So nurse practitioners do consultative work, lots of times that can be quite complex, but done by telephone. So this person wanted a way of reflecting the complexity of her work when she's talking to families and things by phone. There is telemanagement visits, but they don't reflect complexity.
Could be a case conference. Could be case management. I mean, you just have to look at the definitions there.
And then I think we're going to have to figure out, like when you have a care conference in residential care, for instance, it's family and the interdisciplinary team. So we'll have to decide which code we want to use, because one says family, the other one says team. There isn't one for both, so we just pick one.
Well,
And try to
I mean,
be consistent.
yes. So case conference, which would management of the client, coordinating activities, sharing information to meet the client's needs.
As opposed to family conference.
Yeah, so a family conference, if that's only with the family, as opposed to your colleagues, right?
The family conferences are with your colleagues and the family. The family is included plus the interdisciplinary team once a year in residential care. So it's kind of a combination of both of those things. So you just would pick one or the other? Yeah, and that's what I've been
As long
doing.
as we're consistent.
And what about, can I just ask a question about, we said no V codes, what about the E code for the med reviews? That doesn't get recognized either.
No, E. E is medications. That's an ICD-9 code. I see what you're saying. Yeah.
Is it like medication reconciliation or something?
So that doesn't get recognized either.
Or the reef.
Because I've used that a lot.
I think the thing
So I
is,
guess
what,
we'll have to change
from what
that.
you're saying is we have to rechange our thinking. Before, when we encountered with the NP stuff, we tried to capture our practice because we felt like the ministry really needed to see everything we're doing. We need to rethink. We need to change our thinking. And we're not coding like that anymore. We'll code like that for the health authority through our EMR systems, which will capture that data. But other than that, it's just a generalized.
Well, you're capturing it through the complexity codes.
Yeah. But for the NPs in the room, the thing is that I can see where we're getting stuck is because before we used to just code differently with a different mind frame. So That's when we need to maybe, you know, in a further discussion with the department, Pamela, is just continue to revisit this and have some discussion and work together and bring the questions back to the department.
Well, the other thing that I would appreciate is, because we've revised these codes, the complexity rating scale is new. We need to see how it's going to work, because it may need to have some tweaking done to it the more that it's used. So I would appreciate hearing back from you with what are the strengths or the weaknesses, what could be modified or whatever, but use it for a while, and to see whether or not, and then to be able to identify where are some things that need to change. And again, there will be, I've gone through, so the next version of this that will be on the website, and it'll have on here, like right now, this is the version that's 2014. That's what's up now, but the next one will have 2015. So when you're looking at that, you'll be able to see some very slight changes, but adding more explanation around some of these visits that really needed more explanation. Our target is March 1st. Okay, well, thank you. I hope that it makes a little more sense.